Hello, everyone. This is Robin Luther with Susan G. Komen in Wisconsin, and I am delighted again to welcome you to the 2020 Metastatic Breast Cancer Impact Series. We are so glad you could join us for today's session. Before we get started, I'd like you to take a moment to locate the question and answer section on your screen, our Q&A section. We invite you to submit your questions throughout the presentation for our live Q&A session in the second half of today's program. There is a chat box. Don't put things in there that we're trying to disable that. Use the Q&A section and we'll get all of your questions in real time. It is my great pleasure to welcome today's presenter, naturopathic provider Michelle Smekens from Cancer Treatment Centers of America, one of our friends at CTCA. Hello, Shelley. How are you today?
Good afternoon. I'm really excited to get started.
Me too. Me too. Thanks for joining us. We really appreciate it. What is the weather like where you are at?
Cold, dreary, and lockdown.
Perfect day to be inside doing a webinar.
Exactly.
This afternoon, Michelle is going to be discussing metastatic breast cancer side effect management, as well as holistic support for conventional treatments. And if it's okay with you, I'd like to start by giving everyone a little background of your experience. As I mentioned, Michelle Smekens is a naturopathic provider at Cancer Treatment Centers of America. She received a bachelor's degree in international studies from the University of Wisconsin-Madison, and then went on to graduate with honors from the Southwest College of Naturopathic Medicine in Tempe, Arizona, with a doctorate degree in naturopathic medicine. Michelle then completed her 2-year naturopathic oncology residence at CTCA. Shelley has recently co-authored a study on treatment delays in early-stage breast cancer with Dennis Citrin, medical oncologist at CTCA, and she is also currently conducting a study to evaluate naturopathic interventions for women undergoing neoadjuvant chemotherapy ahead of breast surgery. Michelle Smekens belongs to the American Association of Naturopathic Physicians, the Oncology Association of Naturopathic Physicians, and is a board member for the Illinois Association of Naturopathic Physicians. We are honored to have you with us today, Michelle, and very excited to hear your presentation. We've recorded, as you recall, we've recorded your video, so we can start playing that now. And we'll start with your recording. Enjoy the presentation, everybody.
Hi, I'm Michelle Smekens. I'm a naturopathic doctor and licensed dietitian, and we're going to have a discussion about breast cancer side effect management using holistic recommendations while patients undergo conventional treatment. I welcome your questions, and please put them into the chat box in the Q&A, and we will have a good discussion after this lecture. So sit tight, and for the next half an hour, we will talk about integrative oncology for the metastatic breast cancer patient. Okay, so first off, let's do a little bit of an orientation. Most patients have not seen a naturopathic physician, so it's a little bit of a new experience. So what exactly is integrative oncology? We're going to address that and dive into it a little bit. We're also going to talk about certain disease areas and different modalities. So I'm going to talk about surgical support. I'm going to talk about hormonal therapy, specifically looking at hot flashes and bone health. I'm also going to go into discussion talking about chemotherapy and especially fatigue, since that's a common symptom that a lot of my patients experience. And then lastly, we're going to talk about immune support. There's a lot of interest in not only immunotherapy, but with the pandemic, people are interested in immune support regarding viral infections and want to know, how can I optimize my immune system using natural medicine? So the last part of our discussion today will cover that as well. Okay, so I want to make a little bit of a disclaimer. So in this lecture today, this is really just information for you to learn and to share knowledge and for us to collaborate. And I'm not taking the place of your doctor, your team at home. So any information that you get today, I want you to take back to your team and make sure that it's okay for you to use with whatever treatment you're currently undergoing. So this is not a substitute for medical care. Please utilize your physician and your other healthcare providers at home. And if you need any help reaching out to a dietitian or a naturopathic doctor, let me know, and I'd be happy to help you put in contact with one. Okay, so first off, what is integrative oncology? A naturopathic doctor has spent 4 years in a schooling after college. So it's a standalone profession. You would take classes like pharmacy, minor surgery, biochemistry, anatomy. So it would look a lot like a conventional medical school, except that you have extra coursework in things like botanical medicine and midwifery, acupuncture. There's extra hours in nutrition. So you're kind of complementing a typical medical curriculum with extra coursework related to natural medicine. And then after that, you would do a training in the kind of clinical setting of an area of interest. So for myself, I did an integrative oncology 2-year residency because I had a special interest in caring for cancer patients. So it was a hospital-based training where I worked alongside medical oncologists, surgical oncologists, radiation oncologists, caring for patients in a way that was safe and collaborative. Naturopathic doctors also have certifications in other areas like endocrinology or pediatrics. So if you're looking to find a provider, specialization is a good thing, especially when we're talking about taking care of patients with metastatic breast cancer. And I just want to point out too, this acronym that was one of my credentials, FABNO. That means that you took a test, a specialty exam in oncology and showed proficiency. So that would be after you completed your residency, you took your FABNO board. So that's what that acronym means after my name. Okay, so here's a little bit about the philosophy of a naturopathic doctor. So how is it a little bit different? Well, I really want to point out a few things on the slide. Like one of them is doctor as teacher, which is the principle known as docere. So I really believe in my visits with my patients about education. So I'm not telling someone you should do X, Y, and Z. You need to only eat carrots and exercise in your Peloton an hour a day. Like I absolutely believe that my visits with my patients is a collaborative. So we talk about things like glycemic load of carbohydrates, and we talk about things like sleep hygiene. So I believe that that correspondence that we're doing is a lot about education. Also, prevention is a big aspect of the care that I do as well. We're going to talk a little bit about that in this lecture. So, for example, a lot of the hormonal treatments for metastatic breast cancer can cause some changes in bone density. So they can contribute to osteopenia or osteoporosis. So I work a lot with my patients on prevention to keep the bones healthy. Also looking at identifying and treating the cause. So say, for example, someone is experiencing fatigue. Fatigue is not the same for all people. Sometimes people have fatigue because they have nutrient deficiencies. Sometimes people have fatigue because their sleep is not right. Sometimes people have fatigue because they have anemia related to their treatment. Sometimes there's dehydration or malnutrition. So there's different reasons people have fatigue. Also depression. There's a mental emotional aspect of coping with metastatic breast cancer that can be kind of catabolic. And when that's the case, treating the fatigue, the answer wouldn't be just give a multivitamin. The answer in the last scenario would be to help support mood and do a lot of counseling work and reach out to resources to help support psychosocially and family network. And then most important that we're going to talk a little bit about too is first do no harm. So when someone's using natural therapies, that doesn't mean that that's occurring in a vacuum. You have to take in context the other medications or conditions that a patient might have and make sure that everything's compatible and safe to use in combination. Okay, so this is the takeaway, kind of lead in from that last point on the slide, which is that integrative cancer care is different than alternative care. So alternative medicine used to kind of be the verbiage or the popular term, but really what integrative medicine means is it's melding the conventional care with evidence-based complementary therapy. So when I'm making a recommendation from a patient, I'm looking to the research. I'm looking to see what clinical trials have been performed. I'm looking at what's called like meta-analysis, when we took like a group of different studies and we put them together and look at the conclusions. I'm not just making off-the-cuff recommendations or, saying, okay, well, this was used once upon a time in a mouse, and so then therefore it's safe for you to use. Absolutely, these kinds of recommendations are driven from the research, and that's why we call it evidence-based, and that's what that means when we're talking about integrative medicine. And importantly, I look to do the least invasive, most effective approach for a patient. So for example, with the hot flashes we'll talk about today, sometimes someone will come in and they're already taking 5 supplements and they're like, well, give me one more supplement for my hot flashes, but then I'll do kind of a lifestyle review. And I'm like, wait a second, like all your hot flashes happen when you get really stressed out. So maybe we need to rework some of these things that's happening, with these scenarios where you're getting a lot of stress. And oh, wait, you're having a lot of caffeinated beverages before you go in into these like stressful work meetings. Like caffeine can be a trigger for a lot of people for hot flashes. And oh, look at, you're really depending on sugar lately to kind of get you through the day, and blood sugar variation can absolutely cause an impact, detrimental in terms of hot flashes. So I'm looking for the least invasive intervention before jumping to kind of higher or more costly or more difficult interventions. And I just want to point out here too, that us as practitioners absolutely need to support the patient from different aspects. So it's not necessarily that I'm seeing a patient and I'm saying, okay, this is something that's absolutely in my wheelhouse. Like I'll make referrals, or I'll seek out care for them in ways that they might need, that might be seeing another practitioner. So a lot of that is that collaborative environment. And I do that all the time, for this example, with physical therapy. So a lot of my patients with metastatic breast cancer have peripheral neuropathy, numbness and tingling in their fingers and toes. So I'm constantly communicating with our physical therapists or other physical therapists that patient might see, to help them get on board different therapies that they can use as well to help with those neuropathy symptoms. So I want to kind of highlight that aspect of that collaborative environment for best patient outcomes. Okay, now let's bring it home to who's the audience here today, which is the breast cancer population. So in my world, about 80% of my patients are breast cancer. I do see other cancer types as well, but mostly it's breast, and that's my home base. And I just really want to focus my practice and my recommendations for patients knowing these phytochemicals that are in all these plants, vitamins and minerals. So if a patient comes to me with a greens powder they want to drink, I can quickly scan the ingredients and say, yeah, you can take that with Ibrance, or no, you can't take that with Doxil. So I'm just mentioning some drug names that are very commonly used with metastatic breast cancer. So really honing in on the individual drug nutrient interactions is super important in breast oncology, because in metastatic breast cancer, and this is a good thing, we have so many treatment potentials. There's many different hormonal therapies, chemotherapy, targeted therapy, radiation, immunotherapy now on board. So there's so many different treatments, and you have to be really knowledgeable about the conventional aspects so that you understand the pharmacokinetics. So how are these drugs metabolized? Like how are they metabolized in the liver? How are they metabolized in the gut? How are they excreted? And then knowing how those natural agents and nutraceuticals could potentially impact that. So let me just give you one example. There's a very popular drug that's used a lot for metastatic breast cancer called Xeloda. The generic name is capecitabine. That is a very acid-sensitive drug. So meaning if you give something to a patient that affects the pH in the stomach, you can affect how much of that drug is absorbed. So I don't want my patients who are on Xeloda taking their calcium at the same time, because calcium buffers stomach acid, and I could potentially have them decrease the absorption of their Xeloda. So it's knowing not what things can be combined, but also sometimes timing. So if someone needs calcium for bone health and they're on Xeloda, I have them take that, a number of hours away from it, so we're not having an issue of pH interaction with that particular oral chemotherapy. So I hope that makes sense, like kind of looking not only at drug nutrient interactions, but also in terms of timing and appropriateness too. Okay, so we did a little introduction, so I hope all of you feel a little bit more comfortable understanding what integrative oncology is and how it might be different than what alternative medicine used to be thought of. Let's dive in a little bit to the surgical support, okay? So let's just talk, for example, like in the metastatic setting, the situations where my patients might have surgery. I just had a patient yesterday who had a femur rotting because she did have some mets in her femur that was compromising the integrity of her leg and her movement. So that's an example. I also had a patient who had a brain surgery recently because she had a brain metastasis, a solitary brain metastasis removed. So it's another metastatic breast cancer surgical situation. I had a patient a couple weeks ago who had a palliative breast surgery because she had the breast tumor had come through the skin. It was causing her some discomfort. So she had surgery to take care of that and feels a lot better. So a lot of times people will think, oh, well, surgery, that's only for early stage breast cancer, but that's not really the case. There are surgical situations in my metastatic breast population where they are undergoing surgery, okay? So let me give you some examples of some things that I give my patients to help them during surgery. So here's a trial where women were given melatonin after breast surgery, and it showed just at 6 milligrams how they had less signs of depression and kind of basically recovered better after surgery than the women who did not get the melatonin. And I think a lot of that is, you know, if you have, for example, a breast surgery, you might have drains in, you might feel uncomfortable, there might be expanders in, depending on the type of surgery that's done. And the melatonin can really help with that rest and recovery post-op and help people get back on their feet a little faster and really help with kind of the stress adaptation of recovering after surgery. So I do use melatonin a lot in the post-operative period. There's actually some pre-operative studies too showing that melatonin can be helpful reducing anxiety ahead of surgery too. So sometimes I'll use a little bit of melatonin going into surgery to help them with anxiety. I use a lot of a natural medicine called Arnica montana. It's one of the most popular worldwide natural medicines, actually. It's a European flower. It's used to help with bruising or swelling. There is a lot of surgical literature reducing hematoma and kind of the cosmetic outcome of surgeries as well. It's super safe. It doesn't have drug interactions with general anesthesia or pain medication. So you'll notice a lot of times the interventions I use them because they're efficacy, but I'm also using them because they have a low potential risk factor for interacting with any other medications that would be on board or for affecting coagulation, which would be like a bleeding rate after surgery. So the surgeons that I work with here the most often always ask me, can you give so-and-so the arnica, because I'm worried about them developing seroma. So I do use quite a bit of Arnica montana, and it's very popular to reduce bruising, swelling, and seroma collection. Okay, so we talked a little bit about surgery. I want to talk a little bit about hormonal therapy. I think this is really, really relevant for this discussion about metastatic breast cancer, because sometimes you're on hormonal therapies 5, 10, or even longer years. One of my kind of longest, my current, this hospital position I'm in, I've had some patients for about 11 or 12 years, and some of them have been on similar therapies or a multitude of therapies, and we've been kind of managing things like bone health and hot flashes long term because they're estrogen positive breast cancer patients. So I want to talk a lot about that. Also bone health, that's like a long-term game too. And a lot of the medicines we use in metastatic breast cancer, the Zolmetas and the Xgevas and the bisphosphonates, those do require nutrient support because they can cause what's called low blood calcium or hypocalcemia. So when you're on those types of medications for the bones, you need to make sure that you're having adequate nutrient support. Okay, so first thing for hot flashes, I used a lot of omega-3 fatty acids. So that's kind of like what people think about in terms of like fish oil, flaxseed, chia seeds, walnuts are pretty high in omega-3 and relatively inexpensive. It's something you can do through diet or through supplementation. So if someone's up for it, a lot of times I'll give them a food list and we'll try that first. If they're like, hey, like I'm not into salmon and tuna, Shelly, then I'll go ahead and go with the supplement route as well. For people who are vegan, they do have vegan formulations of omega-3 available. They make them out of algae. Also, the flax oil is there. Flax is not exactly the same as fish oil because it's higher in ALA and lower in EPA and DHA. Sometimes that matters, like it matters in terms of like neuropathy and mood. It doesn't always seem to be as important for the hot flashes in my experience, but sometimes when you're looking for high EPA or DHA, which are types of fish oil, those are what's found in the fish as opposed to ALA, which is found in like the plant sources, like the flax and the chia and the walnuts, okay? This is a trial that looked, the first one, 120 women were given an omega-3 fatty acid. This one was high in EPA, and they had reduced hot flash frequency and improved hot flash score. They did almost 3 times better than the group that had the placebo, so it was very effective in that trial. There also was a trial called the LOVE trial where they gave women who had breast cancer kind of more of a vegetarian diet, but they were eating dairy and they were eating eggs, but they gave them omega-3 with this kind of like more plant-heavy diet and found that it really reduced their hot flashes, much more so than the olive oil group, which I also really endorse olive oil use among my breast cancer patients because there's some interesting research that came out of the Predi-Med trial showing some benefits for breast health. So it's not that I'm anti olive oil. I love extra virgin olive oil, but specifically for the hot flash, the research is stronger for the omega-3, okay? There also was a study, I put in the last one on here, that a combination. So sometimes I will combine things for the hot flashes. And here, combining vitamin E with omega-3 was more successful than placebo in reducing hot flashes. And especially the benefits start kicked in after about a week of use. One of the most common errors or oversights that I see with a hot flash intervention is that people will quit things too soon. I'll sometimes have people say, oh yeah, well, I took it for a couple of days and it didn't work. Well, hot flash is kind of our long-term game. So it's one of those things where if you're going to try an intervention, do it for at least a period of 2, 3, 4 weeks. In the example, which we'll get to with the black cohosh, perhaps even longer, because the benefits can kind of start snowballing a little bit. And you see that in these trials when the placebo group and the intervention arm really start separating out as time goes on in terms of hot flash effects. Okay, so I'm going to come back to here to talk about nutrition, but I'm going to talk a little bit about black cohosh because I mentioned it, and we'll go back to the nutrition. With the black cohosh, just kind of like an avalanche of evidence that came in looking at black cohosh for having benefits in terms of the hot flashes, and really importantly for this talk, safety in breast cancer. So didn't have hormonal effects, big reviews. So when I say review, again, I just want to have a reminder that means not just looking at one study, that's taking a combination of studies and pooling them all together and then looking at the outcome. So pooling studies together, black cohosh consistently helps reduce hot flashes safely in breast cancer patients without causing harm to the liver, without impacting hormonal levels, okay? This is important because about probably 15, 20 years ago, there were some reports that black cohosh could elevate liver enzymes, and it did seem to be like one particular kind of product or species. There's different ways to cultivate botanicals, and that's why you sometimes can see different effects with trials. So standardization of botanicals, I'm a really big believer in standardization so that you can say, okay, well, there's this much of this constituent in this herb, and that way you can really compare apples to apples. And with black cohosh, they found that if you do this quality growing and standardization, you purchase from a reputable brand that does these kinds of testing, you don't run into any issues with liver enzymes. There was a study also that came in 2018, I just want to point out that evening primrose oil was helpful for hot flashes. You may have heard of that before, but when they compared it to black cohosh, the ladies who got the black cohosh did even better. But sometimes I will combine them. Sometimes I'll have somebody on black cohosh, but we're not fully getting it there. And then I will add in the vitamin E that I mentioned, or I'll add in the evening primrose oil or the omega-3. So there's not necessarily like a wrong way to do it, but I'll look for other symptoms to help guide that. So say, for example, if someone has, the neuropathy I mentioned kind of earlier in the lecture. Since omega-3s are good for neuropathy, I might go to that if someone has hot flashes because it would help the nerves and it would help the hot flashes. So there definitely is some individualization that occurs with this as well. And then lastly, I want to point out that there have been some publications showing that this is safe to use with LHRH agonists. So that's kind of like your Zoladex and Goserelin. So some of these injections that we're using for ovarian suppression also safe. So to use with black cohosh, because that's the question, right? This is very complex. The hormonal therapy is not just one type of hormonal therapy, not just aromatase inhibitors, not just tamoxifen. So it's nice to see that black cohosh now has been tested across the board with different modalities for endocrine therapy and found to be safe. Okay, and if you guys are interested in the references, they're all at the end of the lecture. We can absolutely share this out. So if you're interested in the research and reading the original articles, you'll see down below I have listed the sources, and at the end of the lecture, all of the references are listed. Okay, so now let's go back up and just talk a little bit about nutrition as well. So with surgery, I really sit down with patients and kind of do like a diet analysis and just make sure, like going into surgery, they're like in tip-top shape. surgery requires a lot more protein, and it does require more calories too. So if someone's going into surgery already malnourished and maybe they've had a lot of weight loss, I look at labs and I'll see that sometimes, the albumin is low or pre-albumin, some of these markers of protein intake. Then going into surgery, I'll kind of like build them up a little bit. I'm like, okay, you have surgery in 2 weeks. Like maybe you're having, I give examples, brain surgery or femur rotting, maybe a palliative breast surgery, different reasons you might in metastatic breast cancer. I'll kind of build them up a little bit going into that. The same can be really said to be true of radiation too. Going into radiation, if it's kind of a big area that's being treated, I'll make sure that they have adequate nutritional support to help with that tissue healing and recovery. We used to think, okay, the old thinking was like be NPO, like nothing by mouth after midnight ahead of surgery. While in the last 5 years, there's been a big push to improve surgical outcomes across the board. And this is not just in the integrative oncology world, this is in the surgical world as a whole. And now they figured out, oh, wow, well, putting people into surgery in a complete fasting state is a stress on the body because you're putting them through an operation, like basically in a fasting condition. So now the guidance is to do these kind of low, slow burning, high complex carb drinks. Like you take one drink about midnight or the night before, and you take one drink about 2 or 3 hours prior to surgery. And what's shown is that patients do better. They stay in the hospital less. They have less infection, less nausea. They have less anxiety. I just give examples of one brand. I don't work for this company. I have no affiliation with them, but they're one of the more popular ones. So here's some ingredients that are in there. So maltodextrin is a slow burning complex carb, but then look how they put some nutrients in there too. Citrulline, which helps with blood vessel and blood flow, zinc, which helps with collagen cross-linking and really immune support, vitamin A. We'll talk a little about some of these at the end of the lecture as well. Selenium, also very important for wound healing and immune support. Malic acid, important for energy. And then after surgery, depending on the type of surgery that's been done, if someone has a wound or non-healing wound, and this is true of my metastatic breast cancer patients who might have a wound not even from surgery, a lot of times I'm making sure that they're getting maybe a high protein oral meal replacement supplement. So that's, people think of Ensure, but I like to use like Kate Farms and kind of like some little bit healthier versions of those, and use those in places where they're not always able to maybe necessarily make meals, and maybe there's some kind of hurdles to doing lots of the protein through diet. You're able to kind of supplement it by using some of these drinks or like bars or some of these meal replacements too. And then we talked about omega-3 in the context of hot flashes and neuropathy. So I wanted to give you some examples so that you guys can have this. Foods that are high in ALA, remember those are the ones that are kind of found in the plants. Foods that are high in EPA and DHA, remember those are the ones that are kind of found in fish and shellfish, just for examples. And you can see how many grams per serving. So on the left side is grams, and the right side is the serving. So you can see, wow, flaxseed oil, very high, obviously, or kind of on the fish side too, herring and some of these smaller fish are super high. It's kind of funny, but I keep in my drawer right here, like I'll eat like all kinds of random like fish, like as my snack out of a can. And some of my coworkers here are just like, oh God, there's Shelly again, like eating like the her canned tuna, or, like I'll have like little things out of there too, sardines out of my can. But, it's a way to get your omega-3 in, and it's super nutrient dense too, and very portable, and you can keep it in your desk for a long time, long shelf life. Okay, and we talked about black cohosh, but I just want to hit on again that it is safe to use with tamoxifen. Some people worry, would there be any more recurrence because tamoxifen is a fussy drug? But actually it's interesting, and I listed out 3 studies here, that there's 3 different population studies looking at women who use black cohosh while they're on tamoxifen, and they actually found less recurrence among them. And it's not totally clear yet why that might be. It could be that they're more compliant because they're having less side effects and maybe they're sticking to their tamoxifen, or it could be that black cohosh in and of itself has the anti-tumor effects that are responsible for that. We don't really know, or it could be a little bit of both. So you don't have to worry though. The outcome studies that they looked at so far have not found more recurrence. They've actually found less. Okay, and I promised you that we're going to talk about bone health. So this next section is talking about bone health, which is super important for metastatic breast cancer, right? For all the reasons we listed. A lot of these treatments long-term can cause osteopenia and osteoporosis. So that can lead to things like fracture more easily. There's even some kind of interesting look at the bone microenvironment, and the healthier you keep the bone microenvironment, that may put some hurdle or inhibition on metastasis. A lot of that's still being kind of researched and kind of like understood a little better, but we want to keep the bones as healthy as possible. So these are the kinds of things that I think about a lot when I think about bone health. Calcium, which is kind of a lot of people know about, but there are some forms that are a little better absorbed. So if I have a patient that's on calcium, but we're really not seeing the results that we want to, either on labs or on DEXA scans or other measurements of bone health, then I'll go to ones that are more bioavailable, easier for the body to absorb. So citrate, MCHC, which is a microcrystalline hydroxyapatite form, which is kind of like a bone meal type form of it. If you divide calcium up into divided doses throughout the day, you actually get better absorption than if you take all your calcium at one time, okay? Vitamin D, I check this on all my patients, just like across the board, all my metastatic breast cancer patients, all my early stage breast cancer patients, I'm monitoring their vitamin D level. The typical range is 30 to 100. We'll talk a little bit more about vitamin D in the immune section. Vitamin K is critical for bone health as well. It's very synergistic with vitamin D. So I make sure people are eating lots of green leafies and some vegetable oils. The bacteria in your gut can ferment a little bit of vitamin K as well. If someone's following a diet that's like, you know, pretty poor on those types of things, then sometimes I'll give them a little bit of vitamin K, or I'll make sure they're on like a combination bone health product that has vitamin K. We mentioned melatonin in terms of like surgical recovery, but melatonin also has been shown in combination trials to help with bone density and bone health. And since melatonin has some interesting anti-cancer properties, aside for side effect management, I tend to use a little bit of that as well when I have some bone health concerns. Okay, so we talked about hormonal treatment, and now let's kind of dive into chemotherapy a little bit. And one of the most common complaints I get from my patients on chemotherapy, honestly, is the fatigue. They're like, I just want to have enough energy to keep working or keep taking care of the family, or want enough energy to like do the things I love or take the trip, or, you know, kind of like achieve a lot of the things, the goals that I have. And the chemotherapy fatigue really knocks me down and keeps me back. So here are the things that have evidence for reducing that, and then the things that I target. Okay, for first off, I make sure that food intake is okay. So people are not eating a diet high in refined carbohydrates, so the blood sugar is going like a yo-yo and making them having peaks and troughs of energy. So diet is first. Secondly, I check hydration. So I check labs, and I also do like kind of take stock of a physical exam. Do their eyes look dry? Does their mouth look dry? Do they have dry skin? Do they have signs? Is their urine really strong and concentrated, or are they adequately hydrated? So I'm encouraging fluid repletion. When we need to, I'll use IV fluids if everything else is not working. We talked about the importance of sleep. I make sure that they're exercising. I know it sounds hard. You're like, oh, if you're fatigued, how do you exercise? But even a little bit of aerobic exercise is very effective for chemotherapy fatigue. And that can mean like putting on your shoes and just taking a walk along the block. Like it doesn't necessarily mean like doing a high intensity boot camp. Like it doesn't have to mean that. Actually, I think sometimes those classes for some people are a little too catabolic right after chemo. So I encourage kind of more gentle exercise as you're recovering, going right after your cycle of chemotherapy. I wanted to point out some of the research as well, which is that in these meta-analysis, remember meta-analysis means taking all studies and kind of crunching them together, they found that exercise improves physical functioning, oxygen consumption, overall quality of life and mood. I do sometimes use botanicals for fatigue. Like if someone tends to be depressed, and like that's an aspect, I'll use rhodiola. If I suspect that somebody has muscle weakness and there's kind of like a real mechanical aspect to it, then I'll use carnitine. Some cancer studies have shown low dose carnitine doesn't work. So I don't do that. You know, I only utilize the higher doses, kind of like adding it to smoothies and things like that to make sure that we're having an effective dosing strategy. I'll use B vitamins sometimes if I suspect that fatigue is an issue, and when appropriate and when it's okay with the chemotherapy. I'll also check for anemia. So sometimes you'll have anemia that's caused from iron deficiency or B12 or folate. Other times the anemia is caused by the disease itself, in which case reducing inflammation can sometimes be helpful for that fatigue. And sometimes the anemia is caused from the treatment. So you have to be able to differentiate different causes for anemia, because you wouldn't treat them all the same way. Not all anemia is true with iron. So sometimes a lot of patients are like, well, I'm anemic, give me iron. I'm like, well, let me check and see if there's iron deficiency, because not all anemia is iron deficiency, and you want to tease it out, but sometimes it is a factor. I also put in some slides looking here at American ginseng, because really this has been kind of like a stellar thing in trials looking at chemotherapy fatigue. 8-week trials have shown that American ginseng outbeats placebo, and especially does that if people are undergoing active treatment. So it works in cancer survivors, but it especially works in people undergoing active treatment. And since this lecture is for metastatic breast cancer, I want to point out things that would work while you're undergoing active treatment. So American ginseng in particular does not seem to have the same like drug interaction issues that you might see with a Siberian ginseng or Korean ginseng. So I do use American ginseng with my breast cancer patients to help them if I'm thinking that they would benefit from that with the fatigue aspect. It's inexpensive, it's pretty easy to get. So it's one of those nice interventions that's pretty easy to try and see after 2 months, are you better? How do you feel? And then let's kind of shift gears and talk about immune support. So this is the kind of the last segment that I want to cover, but it's really important. And I think especially so in the context of this year where people are very kind of hyper vigilant about keeping their immune system supported. Let's talk about zinc. So zinc is a mineral that's especially important for immune function and white blood cells. And zinc and copper are imbalanced in the body. And if you have metastatic triple negative breast cancer, I want you to turn on your ears right now, because there have been trials over the last 5 or so years looking at elevated copper levels may not be the best thing for metastatic triple negative breast cancer. So I am measuring copper levels in my triple negative metastatic breast cancer patients and just making sure I don't see elevations. I do find it, ladies. Sometimes I do find it, and gent, I know there's male metastatic breast. I do find it sometimes, and in those situations, I'm sometimes giving copper to try and lower the copper level. I'm removing copper from the diet. In those trials, sometimes they're using medications to lower the copper. That's a little bit different. Like that requires like supervision, and that's not what I'm talking about here. But I just want to make it really important to know that like zinc does play a pivotal role in breast cancer, absolutely. And then I use zinc a lot during chemo if someone has difficulty with wound healing, or they have taste changes or mouth sores. There's a specific form of zinc called zinc carnosine, and if you need it, we could talk about it at the end of this lecture, but zinc carnosine is very gentle on the stomach, very good for mouth sores, very good for gastritis, like stomach irritation. Other forms of zinc might be a little harder on the stomach, you know, so zinc oxide maybe not the best choice if there's any nausea going on, a little harder on the stomach. And certain chemotherapies can cause zinc deficiency, especially platinum chemotherapy. So if I have a patient on, you know, carboplatin type regimen and I'm seeing some signs, taste changes, like right away, I'm jumping and getting them on the zinc to help correct that. And then vitamin D, I did mention in bone health, but I want to dive into it more because it's just such an important vitamin in terms of breast health. Just every year, more and more and more published on the importance of vitamin D for breast cancer. Look at this, like this is, dosing is key. So 400 IUs, which is kind of what you might find in a typical multi, really doesn't seem to do much in terms of like prevention and kind of having anti-tumor effect. That's why you need to measure a level, and that's why you need to optimize vitamin D levels in patients to achieve kind of some of these, you know, goalposts of where you start seeing some of the benefit in terms of an anti-tumor effect. And I just want to point out too, and I know some of these studies are done in earlier stage cancers because it's easy to monitor them for relapse, and that's why it's done. But they've shown that, you know, even increasing by 5 points, sorry, ladies, let me get rid of this. Even increasing by 5 points sometimes can lower recurrence risk and improve outcomes. And I just want to point out this last study, 2019 study, showed that having too low a vitamin D was bad, right? 1.63 negative, that's a negative hazard ratio for this type of outcome. But being too high too wasn't good. So I might sometimes have a patient who's like going a little bit rogue, and they're like, oh yeah, I'm taking 20,000 every day and I've been doing it for months, and they measure their level and they're at like 220, and I'm like, oh my gosh. So I have to like kind of point this out to them. So I actually keep a copy of this study, and I'm like, look, like you can have too much of a good thing, like most things in nature and medicine and life, you know, you need to have some and you need to be optimized, but too much isn't necessarily a good thing either. So I would encourage all of you, if you're not sure your vitamin D status, to ask to have it measured to be optimized. And then I love green tea. Oh my gosh, love green tea for my breast cancer patients. seems really important in terms of reducing incidence, but also recurrence. It has some really intriguing effects on breast cancer stem cells. Interesting looking at green tea in terms of reducing colds and flus. So there was a Japanese study that looked at healthcare workers who had been vaccinated against the flu, and this was in a pre-COVID era, but among those who had been vaccinated from the flu, the green tea supplementation group still had less flu compared, even if you, regardless of vaccination rate. So the vaccination helped, but if they drank green tea or had the extract on top of it, it worked even better. So I'm a healthcare worker working in a hospital, so I always pay attention to studies like that with good design. So green tea definitely has some antiviral properties in addition to having some benefits in terms of breast cancer as well. I don't use green tea supplements just across the board. There are some drug interaction issues. So when there is a drug interaction issue, I'll either hold it by a window around the treatment, or if someone's on an oral chemo and I can't do that, then I'll have them drink it where you have less catechin concentration and less risk for any drug interaction overlap. So absolutely I support green tea, but with the supplementation, you have to be a little bit careful. There are some interaction issues with certain medications. And then mushrooms. I was talking about how I love green tea, but I probably love mushrooms almost as much. And this is really a relevant slide for metastatic breast cancer discussion, because what things from my world, what things from the integrative oncology world actually have data for reducing mortality, right? Like cause of death from cancer. And mushroom studies have that. Like they have some long-term studies like this, so using people taking these kinds of extracts and substances for long periods of time and reducing mortality. And in short-term studies, they've shown also that you can improve immune parameters. And the mushrooms that I use the most are Coriolis and Maitake and Reishi and Shiitake. So those 4 species especially have data and grit when it's talking about breast cancer. There are other species like lion's mane that are good for mood and cognition. So it's not to say that I don't use other species. I do, but particularly for looking at immune health in the breast cancer population, don't just go to the store and get a general mushroom supplement. Make sure that it has the appropriate strains, and then really importantly, you improve bioavailability of mushroom extracts if they're a hot water extract and not just ground mycelium. So kind of getting into the shroom world here, but hot water extraction improves the level of what's called immune polysaccharides because they're very water soluble, and you'll get more absorption of them if you take a supplement that is a water extraction. If you're eating it as a food, I do encourage using it in soups and broths and teas and things like that, because you could be kind of almost making your own hot water concoction that way. Okay, so I also wanted, and this is what I talked about a little bit, the different species, and I wanted to point out too, because I talked about the supplements, that people do look at population studies of dried and fresh mushrooms and also show benefit as well. Okay, so it's not just supplements. Dried and fresh mushrooms can do it too. Okay, so I welcome any questions that we have at this time. You should feel very welcome and comfortable to have any discourse about anything that I've covered in this lecture, or really any questions about integrative oncology or breast integrative oncology that you have. I'd love to take on your questions. And here are all my sources in case you want to go look at any of the research. They're all here as well.
Wonderful. What a great presentation. Thank you so much. We have bunches of questions. I will be looking over them. Let's start with some that just came in recently about vitamin D. Can you tell people what tests do they need to take to see if their vitamin D levels are regular?
Yes, so there's a number of different blood tests that can look at vitamin D. The ones that have kind of the most standardization and the most data, is the easiest to go by, is something called 25-hydroxy vitamin D. So that's 25-0H. So that's what it should look like when you order it on a laboratory test.
Okay, is that something that's covered at an annual checkup, or would I go to my oncologist?
Yeah, you could ask your primary care doctor, you could ask your oncologist to order that test for you, or a nutritionist to order that for you.
Okay. And as a follow-up, just in general, what is the correct amount of vitamin D to be taking a day, so you don't get into a dangerous level and don't end up too low?
Okay, so in general, I'd say most of my patients need between about an average of 2,000 and 5,000 IUs per day to maintain a level. But remember, I do go based on the lab. So on the lab, I'm looking for them to be between about 50 and 90 on that range, or that 25 hydroxy vitamin D. So I'm some person, like I had a patient today, I had to take her down to 1,000 because she was creeping up already close to the upper end, 90. And then I have some patients that I actually think it's a genetic kind of, polymorphism. They don't really do absorb or maintain vitamin D well, and they need 10,000. On a rare example, I'll need someone with like 15,000, but those are usually people who've had like gastric bypass or like some malabsorption issues. So average person is between 2,000 and 5,000.
Okay, excellent. A question about zinc. Somebody's asking if they can take zinc lozenges kind of prophylactically without a doctor's order to improve their immunity in general. Or is that something that they should run by their oncologist or their physician first?
Zinc is pretty safe, in terms of taking up to like 25, 30 milligrams a day. Like a zinc lozenge is usually about 8 milligrams. So you could safely take a zinc lozenge on your own up to like between like that 25, 30 milligram a day mark without needing someone to weigh in. Going much beyond that, if you go pretty high on zinc, it takes a lot, but if you go pretty high, you can start causing deficiencies of other minerals.
Okay. So when you said the zinc and the copper are naturally balanced,
Yeah,
when zinc goes too high, copper goes down.
correct.
So when copper is too high, you use zinc to bring the copper back down.
I do, but I use a lot more than the 25 milligrams usually.
Got it. So that's more of a therapeutic dose.
Exactly.
Okay, cool. Somebody has asked, when their appetite is off, can they feel confident their body's getting what it needs through vitamins and supplements when they're not feeling like eating? And for a couple days, or is that?
Yeah, a couple of days usually you can make up, but the issue becomes if someone's habitually having time periods where they're not eating well. So if that's the case, then I do end up using a lot of times meal replacement type shakes or drinks where they're pre-formulated to have enough calories and enough vitamins, minerals, cofactors to kind of sustain, body function. So I'll get into like a Kate Farms or something like that, which is like a healthier version of a meal replacement. I'll do something like that if someone's habitually having issues eating, because then I start getting worried that they're not going to get enough calories or nutrients in.
So something like the drinks, and do you recommend a daily multivitamin for your patients as well?
Quite a few of my patients are on multivitamin. Yep, quite a few are.
And someone who's adding like a drink like a Boost or a Kate Farms to their daily diet, just to cover their bases, that would you just be concerned with caloric intake? If you're eating a regular diet but you feel like you might be missing something, can you add those to that mix?
Yeah, so then it should kind of replace like a snack or a smaller meal. So you're right. If you don't want to do like, if you're trying to, because like with breast cancer, it goes both ways. Like you don't want to lose too much weight during active treatment because that can be a bad prognostic thing to become too lean and cachectic and lose too much weight. But on the flip side, maintaining a healthy weight is important too. So if someone's eating well, I wouldn't say, hey, having an extra shake on top of this. It'd be more like in place of, like, you're going to have some unhealthy snack. Well, you could do the shake in lieu of that. But I wouldn't say, hey, take a shake in place of having apples and a handful of almonds and real food. It's when someone's kind of struggling to get in those foods. Sometimes those liquid calories are easy on people when they're not doing well digestively.
Okay, wonderful. A question about the study of supplements. Who is doing supplement study, and who's doing the research, and how are things standardized, and who's approving usages of supplements?
Yeah. So anytime you do research, there's something called an IRB, an Institutional Review Board. So they have to approve any studies that are done in humans. So that's true if it's a drug or a device or a supplement. And typically on that kind of a board would have to be some people who are, medical professionals, physicians. There's also members of the community on the IRB boards. So they have to approve a study design to make sure that it looks safe enough to warrant doing a study. So for example, I did a study with maitake mushroom years ago. I promise you, it was like many pages of paperwork that you have to produce to say, hey, this mushroom's safe enough that we could give it to somebody in a study design and kind of randomize it so that people could potentially be ingesting the mushroom. So there's that. Standardization definitely can vary, and that's why I get a little bit stickler about supplement quality when it comes to botanicals, because that's where I want, like, was it harvested the right time of year, and are they using the right parts, if it's supposed to be the fruiting body or the root or the leaf. So I get a little bit fussy about supplement quality when it comes to botanicals for that reason. Standardization of things like zinc, for example, is a lot easier. It's pretty much all synthesized similarly the same way. Vitamin D as well only comes from like 5 or 6 labs in the whole country, except that it's like what they add to it. So sometimes if people are sensitive to food dyes or things like that, then I got to worry about it. And then going back to the supplement, who's doing the research? Okay, so the issue with funding for natural agents is that you can't patent something naturally occurring. So say, for example, I want to know if oregano is helpful for breast cancer. I might want to do that study design, but the issue becomes I can't patent oregano at the end of this because oregano is a natural occurring substance. So the United States is not going to grant me a patent. So I don't really have a big financial incentive to do this kind of a research. So that becomes a little hurdle. So most of the people who are doing natural medicine research are like academics, like universities or areas like that, sometimes government grants, because there isn't this kind of like financial windfall at the end of it because there's not a patent that can be obtained.
Got it. Thank you. Here's a couple of questions that kind of go together. I know that you talked about sometimes they're asking, can you have too much of a good thing? And you did cover that yes, sometimes you can have too much of a good thing. Are there certain specific supplements that should be discontinued after a certain time? Are there some supplements that are really meant to be temporary to get levels back up? It's not something that you would take on a long-term basis?
Yeah, I mean, there are examples of supplements that I'll give for specific chemotherapies where I'm not going to maintain them long term. So here, a good example is vitamin B6. So vitamin B6 has some data for preventing neuropathy, also hand-foot syndrome with Zolota, but long term, too high of B6 can actually not be good for the nerves. So if someone doesn't need B6, then I pull it back off if they don't need it any longer, because I wouldn't want to use it past the point of its like therapeutic intent. So there are examples of things I would definitely use in the short term.
Okay. Another question is on researching the appropriate dosages. I mean, like, well, for instance, somebody had another question about green tea. So they were talking about alternate forms of getting green tea if they don't like the taste of it. And to relate it back to this other question, if you say green tea is good for you, where do you find out how much tea is good for you? How many cups you need to drink a day? Do you have to use a fresh tea bag every time you make your cup, or can you reuse it? Is that reducing what's good for you? Where do you find those correct dosages?
Right. No, and it's true. And in some of these studies that I shared with you today, there's a range of where they looked at green tea consumption. There have been some studies that have shown as little as 2 cups a week might have a benefit in terms of estrogen metabolism. So like there's some really low level green tea consumption that may be beneficial in general, but then some of the kind of studies looking at active cancer or prevention recurrence are looking more at like 2 to 4 cups a day, like in that range. And they are looking mostly at people having like an individual serving. Now, the tricky thing is, I know in Japan and some other cultures, there is a tendency to make like a single pot and then dispense from that pot. And how do you make that, conversion to like what we would use in the United States as like a tea bag, like, or sometimes people use loose tea. No, it's not perfect that way. And what we're looking at with green tea is something called catechins, and even catechins can range from one green tea species to another. And in general, matcha is much higher in catechin content, but it is more caffeinated. So sometimes I'm working with patients and I'm thinking about that too. Like, are you a person who's sensitive to caffeine? Then a recommendation of a matcha might not be great for you if you're going to do it in the evening and I'm having them do decaffeinated green tea, or I'm having them take an extract that's decaffeinated. So I try to do things through food as much as possible, but the reality is there are some people that don't enjoy the taste of green tea. They think it tastes like the front lawn or whatever, you know, they don't like it. So I try to work with people through food, but if I have to use supplements or if there is an indication and that's easier, I'll do that too.
Okay. Here's another tea question that just came in. She wants to know if you could explain the difference between American and Korean ginseng, and is it safe to drink during chemo?
They're actually they're different species, and I would not use Korean ginseng during chemo because it does appear to have more drug interaction potential. Those American ginseng studies have not shown that to be the case, and it actually has been studied against quite a few different animal studies and some human studies too, not showing an issue with drug interactions. So I don't recommend Korean ginseng during active treatment, only American ginseng.
Okay, thank you. Here's a patient who is on letrozole. She is already doing topical lotions and taking vitamin E to help her with severe skin peeling and cracking on her feet and hands. She's wondering if there's another supplement that might help her with that.
First of all, I'd like to know if that started when they started the letrozole. So that'd be one thing. That'd be one thing. And then wait, what did she say? She's taking omega-3 and already using hand salve, or what did she say, vitamin E?
Yeah, she's doing lotions and vitamin E.
I would like to know if she is allergic to the drug, actually, because I just have thousands of patients on letrozole and I hardly ever see that side effect. So I'm a little bit curious if she might actually be allergic to the drug. You could have dry skin for sure from aromatase inhibitors, but that sounds a little bit more severe. I'd be curious. I would have that patient go back to the medical oncologist because there are other aromatase inhibitors and just discuss the fact that they're having that symptom because that's not typically seen, honestly.
Okay. Okay. Maybe
not to that degree.
Maybe she can fill us in on that.
Yeah, give us an update later, tell her, because my letrozole ladies don't have that. They'll have a little drying, but not like that.
Okay. Okay. Another woman is asking, she's in chemo and AC-T. What supplements should she be avoiding? Or what supplements are recommended?
That AC and T, I would not take green tea during that. I would not take quercetin during that. I would not take curcumin with the AC. So there are a lot of potential, honestly, drug interaction issues with that, kind of a long list. So be careful of the botanicals. In general, if someone is not going to see somebody like myself, like a naturopathic physician, one good way to calculate overlap would be to look at the half-life of the drug and multiply by 5. So for example, with AC or even taxane, the half-life is like between 24 and 36 hours. There's a little variation based on someone's kidneys and liver, but 5 half-lives is like 5 days away, roughly. So then if you know you're 5 days out from chemo, almost none of the drug is still in your system. I'm giving you like a rough parameter. Then you know, okay, well, I'm 5 days out from chemo. Maybe now I can drink that licorice tea I want to drink. I know that's a rudimentary way of looking at it, but if you calculate half-lives, then you know that you've gotten outside the window of interfering or intersecting.
Okay. As long as that brings us right into another question about how do I find a naturopathic specialist in my area? And if that's not possible, how do I find you and you do consultations online? Can you be a remote patient?
Yeah, they can definitely email me, so you can give them my email address. But also there's something called ONCANP, ONCANP, and that's the Oncology Association of Naturopathic Physicians like myself. And that will give you a whole directory. So then you can look in there and see everyone who has this certification sat for their boards. So if they have like the word SPABNO after their name, it means they like qualified and sat for specialty boards.
Okay. Okay. You know, I want to go back to the question that you just answered about supplements to avoid during chemo. The other half of that question is, are there supplements that maybe across the board, since we don't know more about this woman's diagnosis, that you recommend during chemo?
Yeah, with adriamycin, I tend to use a lot of CoQ10 because of the heart protection with adriamycin. So I do use a lot of that. And with a taxane, because of the neuropathy, I do use a lot of omega-3, B vitamins, neuropathy oils. So the neuropathy really becomes a big issue with that. But with the AC, I do a lot of heart support. CoQ10, carnitine, things like that.
Okay. Okay. Are there any specific supplements that you could name that as a group just should never be used by metastatic breast cancer patients? Is there anything that it's like, just stay away from that?
Yeah, like during active treatment, I've seen this mistake made. I don't let my patients in active treatment use glutathione and N-acetylcysteine because they can help cancer like become resistant to the treatment. It's nuanced, and there are some timing things where you could get around it by doing certain times, but on your own, unless someone's having scans and they need the NAC for kidney protection, I see a lot of patients coming in taking glutathione or N-acetylcysteine, and I really would not do that while you're under active treatment for metastatic disease, because there is evidence in animals and some small evidence in humans that it could lead to drug resistance, and I don't want that at all, of course, right?
Okay. If you're okay going a few minutes over, since we
Oh,
got
yeah.
a delay with our sound, I think we've got a few
Yeah,
more
okay.
questions. One is, if somebody's had surgery coming up, and you talked about a couple supplements that helped with surgery, with anxiety tolerance and post-surgery bleeding and bruising,
Mhm.
how do you bring up that topic to your surgeon who might not be working with a naturopathic, if a person does not have this coverage or this
Yeah,
direct.
I think you could mention them. A lot of surgeons do know about arnica, so that's actually somewhat popular amongst the surgical field. So a lot of them know about that. A lot of them are not aware that there's increased data showing that omega-3 is safe. And then the whole thing with using the drinks, like the pre-surgical drinks to enhance outcomes, like some of that is getting more popular too. So I participated in a panel that was like enhancing recovery after surgery. It's called ERAS. And a lot of hospitals are trying to do ERAS and enhance outcome of surgical patients. So they're looking, and so they're learning about these like ClearFast and other brands like that using these kind of like low glycemic, slow burning carb drinks during surgery. So I think it is becoming more popular, but you can always share with them. Like, don't be afraid of your providers, and especially if you come at it in a way that's like kind and not, antagonistic. As long as you come at it like, hey, I learned about this, like, what are your feelings on that? I think people are a lot more open-minded than if you kind of come at it like, I'm doing this, or, kind of storming the barn, that type of thing. So I would just say to share with them anything, and the references are all in this talk at the end. So if you need any like clinical references, they're there. I also would like try to pick things that weren't too fringy. Like I've tried to pick things that were like pretty solid in terms of like awareness, so that it wouldn't be you run into that challenge. I try to pick things for this talk that were a little bit more closer to the mainstream.
Okay. Someone's curious, when you're working with a patient, how often do you confer with their oncologist?
A lot. So yeah, a lot. So at CTCA, we work like alongside each other in the same clinic. So at my hospital job, I'm like alongside people all day long, talking constantly with the medical oncologist. In my private practice, it's a little bit more of an effort that I have to make to send letters or emails, but I definitely try to do that because I want to make it easier on my patient's behalf. And I think best possible outcomes for patients is what we should all be after. And I do think that good care, collaboration, and coordination, is something that we should all be working on.
Excellent. There's just a couple left. One is, you talked about melatonin as something with surgery. Somebody's wondering if they can do melatonin just as a sleep aid without worrying about using that, or is that something that they should?
Yeah, melatonin has very few interaction issues. Actually, like, it's very good safety profile of melatonin. The only contraindication really would be, there are some people who have depression in the morning that can be exacerbated. So melatonin is great for anxiety, but if someone has depression, especially in the mornings, and they get a hangover effect of melatonin, that's not the best sleep aid. Then I'll choose something else.
Okay.
But outside of that, honestly, like my anxious patients do really well with it. And there's a lot of oncology studies with melatonin. So there's a kind of a big collection of research.
Mm-hmm. And one last question, I think we might have them all. You talked about hydration briefly. They're wondering, how does hydration factor in general into maximizing the benefits of exercise, a good diet, and supplements? And if they are fed up with drinking too much water, what other liquids count as hydrating yourself?
I mean, I think that you should make it more interesting. You should do teas, and you could do coconut waters, and you could add, like, I'm not a big fan of using too much juice because of the glycemic load, but a little, maybe put like 10 to 20% unsweetened cranberry juice or tart cherry juice. Like, it doesn't have to be that boring. Like, you can absolutely make that. And I love like making hot teas and warm drinks in winter. And I have my patients do this turmeric ginger bomb sometimes if they have inflammation. So like, there's different ways. Like, it shouldn't have to be boring. Like, if you're tired of just plain water, it's time to gussy it up a little bit. And they even have those like infusers. Maybe you've seen those where you can like cut up citrus fruits or fruits and like put them in a little, it's like almost like a little basket thing that sits in the water. And then all day
Right,
you're kind of getting
right.
the essence of the fruit that, yeah, it shouldn't be boring. If you're like burnt out on just water, it's time to mix it up.
Excellent. Well, Dr. Smekens, this has been a wonderful presentation, and we really appreciate your great answers to all these questions. I'm wondering if there's a final thought you want to leave people with today.
Yeah, I've worked in breast oncology for over a decade and I love it. And one of the reasons I love it is because the patients are motivated and, the visits I have with people are like always like fulfilling and I love it. And also because the treatments are so good. So some of these patients I've been working with for over 10 years, I had metastatic disease when I met them 10 years ago and they still do. So like, I have long-term relationships with my patients and I just wouldn't have it any other way. I'm glad that 80% of my practice is breast cancer and I wouldn't have it any other way.
Wonderful. Well, it's a pleasure to meet you. We're so glad you could be here with us today. This is Michelle Smekens from CTCA. I know that everyone watching is joining me and thanking you for your wonderful presentation and taking time to answer the questions.
Thanks so much, Robin.
Thank you. And I'd also like to, thank you to everybody. That was my next thing to say too. I wanted to thank everyone for coming in and for their time, taking time to watch these presentations, yours and the ones that preceded it. I'm hoping that you found them enjoyable and enlightening. We'll be moving the video of this presentation along with the other series presentations onto our YouTube channel so you can continue to view them and share them with people who've missed them. So thank you again, Michelle Smekens from CTCA, and thank you to everyone for taking part in the 2021 Wisconsin MBC Impact Series. We hope this has been a helpful and powerful learning platform for you. For a few more days, feel free to keep engaging with sponsors and organizers and participants on the Whova app, and we look forward to connecting with all of you again very soon. Enjoy the rest of your day, everyone. And a last thank you to you. Bye-bye. Thanks so much.